One of the things that, we're talking about detecting new lesions, and in many ways, this is really why the meeting was held and why Don Patey came up with the idea of a standardized MR. Because in order to be able to see a new lesion, particularly if we're starting to reduce our use of gadolinium, because all we want to know is what happens within the past year, having two scans that are as similar as possible to each other allows you then to detect a new change. Because it's possible that if the patient moves between the scans and the scans have not been performed in exactly the same way, they may be of different thicknesses between one scan and the next, that you may not be as certain as a radiologist that this is a new lesion.
Right.
And being able to identify that new lesion may have consequences in terms of the management of the patient.
No, and you bring up a good point, and a large part of the meeting in prior meetings is talking about, what Tesla strength is needed. Is it 1.5, 3T? And I know in our area, based on the payer,
Right.
sometimes you don't have,
Right.
a choice. We like to try to get patients in a 3T scanner, but sometimes the payers say, no, you're going to go down the road and get on a 1.5 T. I think the most important thing for me is comparing apples to apples, right? So if someone's on a 1.5 T, then to keep them consistently on the same scanner.
Yeah, although
even if
it's difficult. It's really difficult. I work both in Amsterdam and in London, and we have between 5 and 7 scanners, and it's really difficult to schedule the patient for the next visit on the same scanner. And I think so. The Magnus Group did a study comparing head-to-head 3 Tesla with 1.5 Tesla. So people had a same-day scan when they had a clinically isolated syndrome, and then the follow-up scans as well. It's quite a tedious study, and we had anticipated that we would be more certain or more frequently make the diagnosis of MS based on the 3T, but in fact it wasn't true. Although you see slightly more lesions, if you have good quality flare scans, they're really quite comparable in picking up the relevant lesions. And conversely, we had anticipated that there would be issues doing good spinal cord scans on the 3T. And the quality is not as nice and crispy as a 1.5, but in terms of diagnostic quality, it was performing equally well. So I think progressively these machines are maturing. The 3Ts are getting better in the spine, but the 1.5s are getting better in the brain. So I think they are comparable, and it's important, as David said, to use the same protocol. And I think 3D FLAIR, which is my favorite sequence, is really very helpful, because if you get it at approximately the same resolution, you can reslice it in multiple directions and always make a fair comparison between time points.
One of the things is that is important, besides using the same protocol, is making sure as much as possible that the same scanner can be used. Scanners will change over time, there's no question about it, but during the short period of time when there is the capacity of being able to return to the same scanner, that's better than jumping between scanners, because there will be some differences between the scanners. And as much as possible, if the scans are comparable, then it makes it possible for us as radiologists to be much more confident in saying that there is a new lesion, and for you as a neurologist to feel comfortable that you have information to help you guide what you want to do and discuss with the patient.
So a question in Vancouver, if patients aren't coming to the medical center and they're getting scans from the outside, how realistic is getting the patient on the same scanner, even in the same radiology center? Because I've had some challenges doing that. I totally agree. I mean, ideally, we'd like the same scanner, same facility, same, patient in the tube at the same, angle, because we have our challenges.
Yeah, we have those challenges as well, and what we've been trying to do is work on the state or provincial level to try to harmonize so that the protocols are similar at all the different centers, and try and have the patient go to the same center. And it brings up another issue, of course, which is people move.
Right.
And how do you'd hate to lose all that important information they've had from previous scans. And so one of the, I think, the important things is in order to compare over time, if people are moving, that they bring their data with them. They bring their MRI studies on a CD or a flash drive so that when they go to their new center, there can be some attempt at comparing studies over time to get a better idea and actually, save getting unnecessary scans, paying for those scans.
So I have a quick question for you. So let's say someone does move and they bring, their flash drive or whatever, and they establish care with a new provider, and say the quality of their prior MRIs are, maybe subpar, the, more current MRI that they're getting is a bit better quality, and the neuroradiologist says, well, maybe there's a new lesion compared to the outside film. What do you do clinically?
In those situations, I would certainly want a new baseline MRI. And if I don't have a baseline of the spinal cord, I'd want a baseline of the spinal cord too. So I'd like to establish a new line in the sand for future comparison. Depending on the patient's profile, I may or may not request that with gadolinium. It all depends on what stage of the disease they're in, if they're on therapy, if I'm concerned there's a lot of breakthrough disease activity. But getting a good quality new baseline scan can be invaluable in the future care of that patient.
And do you ever do a shorter interval MRI after that, at 6 months versus a year, or do you just go based on sort of that clinical presentation?
I'm kind of old school clinician. It's really based on the patient's needs. So if they're on stable therapy, well-established MS, there's been no changes in their profile, I might get an MRI every 1 to 2 years. If they've got long-standing, essentially burnt-out MS, they don't need MRIs as frequently. But if there's a lot of dynamic changes in their clinical profile, they're switching therapies, I think we need to image them more frequently just to make sure we're going down the right pathway in terms of disease control and safety. I think one thing we've talked about was the risk of infections.
I agree. So I think if patients switch therapy, it's good to establish a new baseline and preferably not just before they start, but 3 to 6 months into the therapy, because some therapies take a few months to become fully active. So re-establish a new baseline after 3 to 6 months and then start your sort of yearly monitoring. And as you said, if there are drugs with safety concerns, for example, around PML, you can do more frequent monitoring, especially if people have antibodies against JCV virus in their blood, then you can go to more frequent scans and then use an abbreviated protocol. Just the flare and the diffusion is sufficient to rule out PML. You don't have to do the full works, including gadolinium in those patients.